All right, everyone, welcome and thank you for joining. My name is Ashley Lusick, and I am a health educator for community health at Atlantic Health System. Today's webinar, Understanding Hormones as We Age, is presented by Dr. Christopher Simons. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or the chat for comments. We will try and get through all questions at the end of today's presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with groups available in person or virtually. For more information about these groups and other resources, or for additional dates and times, please call 1-844-472-8499. I am now going to turn it over to Dr. Simons.
Hey guys, what's going on? How you doing? My name is Dr. Christopher Simons. I am an OBGYN. And today I'm going to be doing a very basic presentation on that's going to focus on female sex hormones and kind of hormones from different age groups of women and kind of what to expect at different age groups. It's a very basic talk. These topics can be very, very large and very overwhelming. I think that I spent 4 years of residency and 8 years of school postgraduately to kind of understand these things. So it's going to be a basic overview. So we're going to talk and touch on a couple of different things and, go through some stuff, especially like menopause and postmenopausal hormone therapy. However, if at any point anyone has any questions or, comments or things they want to talk, raise your hand. I'll try to get to them if I notice. But again, it's just going to be a basic overview that we're going to touch on. These subjects can be really, really large. You can probably spend a career talking about them. So, yeah. All right. I'm getting it. All right. So this is about me. So a little bit just to talk about myself. Now, I have now worked for Atlantic Health for 2 years. My primary office is Hackettstown Women's Health. I work both out of Newton Medical Center, Hackettstown Medical Center. I did a residency as an OBGYN at Michigan State University. Go green, go white. I have a father of 2 beautiful children. I've peppered in some pictures of them at the end. I am a former pest control technician. I used to get bed bugs and cockroaches and mice and catch all sorts of fun animals. What else about me? I have no disclosures or sponsorships. Not yet. Hopefully I can get some in the future to supplement my income. Just kidding. And then I collect oddities. I love Halloween. Those are kind of all about me. All right, so yeah, there's some of my oddities collection. And there's me with my family and my son Milo having a great time for every picture. He does not like to ham it up like I do. And there's my wife Alicia, and that's us and me. Okay, so on the agenda, first we're going to kind of define what hormones are and our basic female or biological female sex hormones. We're going to talk a little about puberty, adolescence and adults, perimenopause, menopause, and postmenopause, kind of some things of what we can expect. Okay, so there's God inventing hormones, and then there's us OBGYNs on the phone getting rich because that's what we do. But again, just I love memes, so. So, kind of what hormones are, right? This is a basic talk. So we're gonna talk about just some basic concepts and ideas. So what is a hormone? A hormone is a signal molecule that is released by an organism, whether it is a dog or a cat or a human, and its job is to release it is a biologic signaling molecule. And so it's designed to be released by a tissue or organ in order for us to affect a tissue downstream. So for this lecture, we're really going to talk about the basic female hormones, and those are involved in the hypothalamic pituitary ovarian axis, and they're involved in puberty, sexual development, fertility, menses, in menopause. Okay, so Jackie, so why the interest specifically in this field, considering that both my wife and I are young? So there's interest in hormones and in this field because it's kind of part of the spectrum of OBGYN. Um, it is so hormones, and you talk about women's health. I a lot of times take care of young women who are getting pregnant, and then if I have an older woman, a lot of times their hormone levels are going to differ very much depending where they are in their journey. And so you kind of with hormones, this is one of those things that understanding the cycle, you can treat women who are both young and treat women who are both older, because it really depends a lot on where they are in their life. And so I got into OBGYN probably because it's a lot of fun. There's a great opportunity for jokes, but also you're doing different things every day, and that's part of the allure. Also, you're often with patients on the best day of their lives sometimes when they're giving birth or having a baby, and you get to do some surgery, you get to be in the office. It's kind of, a smorgasbord, if I'm using that word correctly. Okay. All right. So thank you, Carol. So this is essentially what we're going to talk about today. And this is a feedback loop. We have your brain and your hypothalamus, your pituitary gland. And these are the hormones that are kind of involved in puberty and the menstrual cycle when we're talking about patients that are biologically female. And so really we're going to talk about feedback loops. So what is a feedback loop? A feedback loop is a system where negative or positive input can be used to alter the system. So in our bodies, this is kind of always working towards hemostasis or balance in our bodies. This is important because most hormonal systems work with a negative or positive feedback loop. If something in the body is unbalanced, it could be a diagnosis of a problem. It could be just a regular imbalance. We oftentimes make these diagnoses by figuring out where in the feedback loop is abnormal. And so going back, going back to this loop here, we can make a lot of diagnoses as, clinicians, kind of breaking down this loop. If our loop from the brain is signaling too much, it'll send too much to the pituitary, which will send too much downstream, and then that'll have too much estrogen at the end. And we can kind of make diagnoses based on where errors are in this feedback loop. And so that it's going to be important, and I'm going to go back to these slides a lot to kind of explain why these are so important. And if any of you are my patients, or any of you are students that are working with me, you'll find actually that I use. Oh, that's I have holding a whiteboard. You can't see because it's just getting me in the background. But I do use a lot of whiteboards for teaching patients so that they kind of understand what's going on. So first, along this cycle, we're going to talk about the brain. Your brain starts everything with hormones. So we have gonadotropin releasing hormone. This is released, secreted by the hypothalamus, and this is kind of the starting hormone. It's the starting gun at the beginning of the race. It is an important neurohormone, and it signals gonadotropins in the anterior pituitary gland. Gonadotropins, think of like gonads. So in a female, we're talking about ovaries. In a male, we're talking about testicles. But your anterior pituitary then stimulates follicular stimulating hormone, and that produces eggs and develops eggs and estrogen from the ovaries. And then you have luteinizing hormone, which promotes estrogen secretion with a positive feedback loop and possibly supports pregnancy. So GnRH, I might refer to that as, instead of saying gonadotropin releasing hormone over and over again. It's the initial starting hormone in puberty, and it's used to ramp up that anterior pituitary gland in the beginning of puberty. It goes in a pulsatile fashion, and that anterior pituitary gland synthesizes and creates the FSH in response to this. And so these hormones work, like I said, on male and females a little different way, but today we're going to focus on that biological female. Okay. Okay, so again, going back to here, we're going to keep going back. You guys are going to be able to draw this picture for me if you comment. But we have that hypothalamus, and I don't know if you can see my mouse moving, but the hypothalamus talks to the pituitary by releasing that GnRH, that pituitary gland. It grows when you're going through puberty. It starts releasing LH and FSH, and that in turn starts stimulating those ovaries, which are going to create estrogen and progestin. Oops. So estrogens. Okay, so estrogens are probably the biggest hormone that you're going to talk about as a female. They are made by the ovaries. They stimulate growth of your endometrium or the inside of the uterus and make it thicker. If I'm talking about abnormal bleeding, I usually say estrogen makes the grass grow, the grass being your endometrium. It surges within your cycle in response to LH and can create ovulation where you release an egg. And it stimulates secondary sex characteristics. So we think about breast development, we think about growth of the vagina, we think about different hair growth in different places as well can be affected by estrogen. You have a set number of eggs at birth, and then following the beginning of your puberty and hormones, it slowly releases and declines over time. And long-term, estrogen-sensitive tissues are the breast, the vagina, the uterus, but also those tissues can support urinary tract and areas of the pelvic floor. And estrogen has a protective effect against on your bone and as well as your heart. And it can also help development or keep your hair and skin kind of the way it's naturally. Okay, progesterone. The best way to remember progesterone, and I still do this for medical school, is progesterone is progestation. It is to support a pregnancy, generally. It is released in the second half generally of the menstrual cycle. And it's released by the ovaries as well as the corpus luteum, which is a cyst that comes with ovulation. And if you get pregnant, it goes with the placenta. Oh, that's hold on. Oh, yeah, there we go. It prepares the endometrium for implantation with a possible pregnancy and can support that pregnancy. It's one of the key ingredients in birth control, and you'll see many progestin-only birth controls out there because if your body thinks it's pregnant already, it is not going to get ready for a second pregnancy. And so I tell people, while estrogen makes the grass grow, progestin works as the lawnmower. So it keeps that endometrium kind of where it needs to be and keeps it looking tidy. Again, we're going to talk a little bit more about this. So here's next slide. So this is a easier version of our feedback loop. So you have your hypothalamus talking with GnRH to your anterior pituitary gland, creating FSH and LH. Those talk to the ovary. Estrogen works with a positive feedback loop. So estrogen comes out, makes you ovulate. And then progestin comes out when you ovulate, and then that turns everything off. This is kind of a hard concept to remember and gather over time. However, it will hopefully make sense, after I hammer it into your guys' memory. So I like this picture. I use this in my latest talks as well. And this kind of, what I went through 8 years of postgraduate education to learn this is exactly what I say. But we have the top, we have your ovary releasing an egg. We have your body temperature here with ovulation. We have luteinizing hormone and follicular stimulating hormone, estradiol, progesterone, and your endometrium. So this is your entire menstrual cycle right here on one page. Day 0 is when you're first bleeding. And then by the time it stops, we have egg development here, ovulation, and then your estrogen goes down, progestin takes over. And then if you don't get pregnant, it goes away. Okay. I don't expect you to memorize this, but it is a good, chart to go back because it can kind of tell where you are in your cycle or what your hormones should be like, based on your cycle in a normal biological female. Okay. Or regular biological female. So there are other hormones that are involved in normal development, right? Okay, so we're going to talk about, real quickly, we're going to talk about testosterones and androgens. Everybody has them. every woman out there on the planet is going to have some level of testosterone. They are biological male sex hormones. However, they are present in low levels in most females. They are highest when you're adolescent in females, and then they decline gradually over time. Some patients, I do field a lot of questions about what is a normal testosterone. Well, a normal testosterone is in a young woman is low. We don't have exact levels that they should be, and we don't recommend monitoring them. However, sometimes if you have high testosterone, that could be a sign of a pathologic process, like congenital adrenal hyperplasia. That's where your adrenal glands are bigger than they should be and firing too much. And that can present with hair on your face, like, male pattern facial hair like me, or some, fashion like that. Or it might hair on your back or hair thinning or hair on your chest. It can present as abnormal periods. It can present as heavy bleeding, or no bleeding at all. And so this is oftentimes with PCOS, it's a product of excess estrogen. When you have excess estrogen, there's too much androgen and too much precursor to making estrogen. And so what I tell patients with my patients with PCOS is that if there's too much traffic at the tunnel, someone will take the bridge, and that's exactly what happens. They have too much estrogen. Some of that estrogen is converted to testosterone. And that can be very, very common in young women, can be very common with women with obesity as well, because obesity can have a positive feedback loop product on estrogen and create higher levels of estrogen. So a lot of times I'll get questions about, should testosterone be supplemented in older patients? And there was some theories out there that patients with low sex drive might be low in testosterone. But the problem is that testosterone is a very powerful hormone, and supplementing it generally was not seen to improve patient outcomes. And then monitoring it for women was also not proven. So from a clinical based standpoint, treating them with testosterone, monitoring testosterone in patients without symptoms was not recommended and not shown to be a benefit. And then actually supplementing with testosterone can actually cause harm, like those adverse, male pattern sexual characteristics. So even though you do have circulating testosterone, it shouldn't be super high. And again, it kind of gradually declines over time. So it is not something that we're not going to talk too much about it, but I will field questions for people just because this is kind of a basic talk. Oh. So, and then there are others. There are lots of other hormones. And again, if we had a full 4 years of medical school, or if we had multiple talks about each, we could probably spend an entire day talking about each one of these hormones. But like human chorionic growth hormone, or HCG, that is a pregnancy-related hormone. Prolactin is a lactation hormone. These hormones do affect our feedback loop, our basic feedback loop, and can change things downstream, change your periods, or change how you're feeling. There are also adrenal glands, thyroid glands, neuromodulating hormones, and there are a bunch of different major groups. They have complex functions and complex relationships. When talking about hormone health, usually those are things that we might draw some of these hormones, like thyroid hormones, etc. We'll probably draw those in patients that are symptomatic, but we're not going to get into each one of those today because it's just too big a topic. But there are some things that we can somehow sometimes talk about in the future, especially for patients that are having symptoms or problems. Okay. So we're going to jump over to puberty, and it's like when we evolve, like Pokemon, for those of us that are 90s kids. So puberty, it's a biologic, social, sexual, and also, again, I want to focus on, it's also a social maturation. We always talk about biological and sexual, but it's also a social and developmental maturation as well. You have a growth spurt and also the development of secondary sexual characteristics. You have breast development, pubic hair, growth spurt, menses. It's triggered by pulsatory GnRH, mostly during sleep. The timing can vary, but tends to start at age 8 to 9, typically with like armpit and pubic hair, and then breast development, then a growth spurt, then menses. And then menses is on average at age 12. However, in the US, it's actually happening earlier and earlier. It can happen earlier with certain ethnicities. African American women tend to go through it a little earlier, just here in the United States. And there actually is talk about looking at different hormone levels, especially of a satiety hormone called leptin. And they're looking at higher levels of leptin in early puberty in the US. There are some actually interesting studies that are going on, but I won't won't bore you with that stuff right now. So expectations, right? If we have any very young women, or more likely if we have moms or people that you might know that are going through puberty, kind of how to talk about that. So expectations, your androgens and estrogen increase, right? So you have pulses of these brain hormones that are going up, those go up high, and then so they work downstream to increase the androgens and estrogens. So testosterone is high, so you have hair growth, you have the underarms, pubic hair. Estrogen is high, so you get breast budding. They also, because of the brain pulsating, you get growth spurt. You can have many symptoms associated with fluctuating hormones. I don't know if anybody else is old enough to remember Peter Brady and going, "Ah," with the voice, but you get voice changes, you can get acne, you can get mood changes, weight gain, bloating, breast tenderness, hair changes, depression, anxiety, sexual libido and interest will go up with these hormones, and you can have irregular cycles. So we go back here, right? The hypothalamus at a pulsatile faction, it's releasing a ton of GnRH. That's making the anterior pituitary gland go up and go up and go up, creating more FSH and LH, which are stimulating those ovaries and making more and more estrogen. And then estrogen is making those ovaries grow, and it is making a positive feedback loop, which will start menstruation eventually. Okay. So when to seek help, right? We have lots of people say that, you can kind of say everything is, oh, they're going through puberty, that's nothing to worry about. Well, sometimes there is. So the first thing I want to say is that this is a lecture. There are going to be lots of questions. There are going to be things that you don't remember. However, anytime you guys have questions, reach out to your healthcare provider. Reach out to a women's health provider or your general practitioner. The worst thing they can tell you is that they don't know. They might need to ask someone else. So I tell my patients, anytime you have a question, you reach out to me on my chart, message me. I don't always get back to you right away, but I do answer eventually. But when to seek help for the pubertal or prepubertal patients is appearance of sexual characteristics before age 8. I tell patients to reach out if their children, are developing breasts. It can be normal in some patients, however, it can signal a problem in others. If you have a rapid procession of these sexual characteristics, right? If you had a child who developed breasts at 8 and they were getting their period within 6 months, that is, definitely something that needs to be worked up because they might have something wrong along that feedback loop. So menses prior to age 10 or no menses by 14, especially in absence of other sexually set characteristics. If they have prolonged or regular bleeding, if they have onset of these things or no onset of these things with headaches or visual changes, that can be weird. Or anytime they have severe abdominal pain, or actually 14 years old is just a great time to establish care. 14-year-olds have a lot of things that we can address, and I tell my young patients, that doesn't mean you're getting a pelvic exam. I don't do pelvic exams on young women unless they're having a problem. It's a great time to talk about sexual health and prevention, acne, birth control, interpartner violence, substance use, and kind of establishing care. Coming in for a 20-minute talk to talk about these things can sometimes make young women feel very comfortable moving forward in a very critical part of their life. So tips on healthy hormonal habits. The biggest thing I could stress in this age group is communication, right? Education and communication. The more things like this that we do where we're talking to patients about their hormones and what to expect, normalizing talking about sex, intimacy, substance abuse, and dysfunction, and counseling patients that their periods can be very abnormal, their hormones can be fluctuating crazy at this time. Can be very good for them. Diet and exercise. So our 14-year-olds, they are getting their habits that they're going to keep for life, right? Diet, exercise, and BMI. So you address healthy activity, healthy diet, mood and personal perception, and identifying delayed and precocious or early puberty. You can also talk about menstrual habits and safe sleep habits, or healthy sleep habits, not safe sleep. Because, like I said, in this time, kids need sleep, or young adults need sleep because of that pulsatile GnRH, because that's kind of where they're going to have their things coming. All right, I got a question. So I'm going to talk about atrophic changes when I get a little further down the road. And we'll get there fairly quickly because we're going to talk about adolescents, adults, and then we'll get back to that. So let me go to, okay. So now we're talking about adolescents and adults. So I know that we kind of divide up adolescents and adults. However, it is really an adult, even though socially we don't consider, a 14-year-old an adult. From a hormonal standpoint, it's when they're sexually immature. And so that means that they can, have completed development of their secondary sexual characteristics. And that will continue, through their teens into their early 20s. However, if they're sexually mature, they're ovulating and their menstrual cycle should be regular. When I say regular, that means 21 to 35 day cycle with about 5 days of bleeding and less than 80 milliliters of total blood loss. They're going to have cyclic estrogen and progestin with a low FSH and low LH and fluctuated hormones. And so yeah, so we'll go back. So sexually mature, that means the beginning of the cycle, we have a low estrogen, and it's growing and then peaks before ovulation. It then gradually declines and progestin decreases. So if no pregnancy, the progestin plummets and causing a hormonal withdrawal and shedding of the endometrium. And so then we go to our picture here, which should show, I know that might be hard to read, but here in the beginning of the cycle, around day 0 or day 1 to day 4, that estrogen is low, going up, going up, going up, and then peaks around day 14 and then goes back down. And so this is what a normal menstrual cycle should look like. It doesn't look like this for everybody. It might be prolonged, it might be a little different. And then 2, I'll talk about those questions. I'll get those at the end of the lecture, or at the as we get a little further on. So expectations with just regular hormones, like, so let's say a patient comes in and they say, I think my hormones are off and I want a level to be done. They're saying that, my mood is different, my breasts are tender, and it can be due to different days in my cycle. Well, the drawing of labs is really dependent on what day in your cycle it is. And so if a patient is having abnormal cycles, it can be difficult because we know that at different points in their cycle, right, they're going to have different levels of these female hormones. So a lot of times it's important to kind of say, all right, well, we're going to draw labs in the day 3 of your cycle or day 21. So it's really important to kind of coordinate where we are in the cycle. And unfortunately, many women are coming in because their cycles are abnormal. So I kind of talk to people about taking a diary of their symptoms and a diary of where in their cycle, you maybe even using an app, because hormones can vary wildly person to person, day to day. And so many symptoms might be related to it, but they can be related to something else. And so labs can kind of give us a clue, right? If we're getting a lab and your FSH is super high in the beginning, we know your ovaries kind of aren't functioning where they want to be. Your brain's having to release more hormone to talk about it, or to get your ovaries to function normally. And so estrogen should be high at the middle of your cycle, but normal. But if it's too high in the beginning, it can cause excess testosterone, and we could be concerned about something like PCOS. So again, diagnosing of these problems, right, is kind of looking back at this chart and seeing what day in the cycle we are, and then kind of looking at our hormones and seeing where in that feedback loop may potentially be dysfunctional. Okay. So, So tips for our kind of young women or menstruating women who are, um, trying to maintain a healthy hormonal balance. That's our thing today. So again, we're going to go about diet and exercise. And one of the reasons why we talk about diet and exercise so much is that when we have an elevated BMI, it creates a higher baseline estrogen and can also work by having a negative feedback loop on your ovulation. So it creates longer cycles. We have a prolonged cycle, and then it can actually work almost as a birth control, and it can create excess estrogen. And this is a lot of times what we see in a patient with PCOS. Try to maintain a normal BMI, try to get a healthy amount of sleep and productive sleep. You don't want to, broken sleep where you're waking up every couple of hours, or if you're, not sleeping enough hours. Kind of all of those things can affect downstream if you're not having your pulsatile function of your brain. Also, keep a tracker of your menstrual cycle, a diary of your symptoms. Avoid alcohol, tobacco, drugs. Ask questions about what medications you're on. Lots of medications can affect that feedback loop. And then also have healthy sexual activity. Having sexual activity, even if it's masturbation, keeps those tissues well vascularized. And also think about regular communication with healthcare. If you're having normal symptoms, normal things going on, that doesn't mean don't be seen, but it can just help with hormonal balance. And then for many women, this might also mean taking birth control. We use birth control as a tool to help regulate women's periods. Instead of thinking it as like adding hormones in, I kind of tell people that we're just deciding what level of your hormones should be. And we'll talk about that just for a second, but when to call me anytime. There are no rules. You can call me anytime. Feel comfortable. If you're having heavy or prolonged bleeding. So, right, if your period is greater than 7 days and it's greater than 7 days all the time, or you're just having symptoms that are interfering with life, you're bleeding where you're soaking through a heavy tampon or pad every 30 minutes, or within the course of a few days you're bleeding more than 80 mLs, and that can be hard to figure out how much it is, but there are some Google images and things that you can kind of figure that out, or weighing your pads. Let me see. Okay. If a young woman was diagnosed with PCOS, does it go away as she gets older and testosterone declines? Also, can PCOS cause infertility? So just because we're on that young women and we're talking about PCOS, let me answer this question. So first off, PCOS is a spectrum of disease, polycystic ovarian syndrome. Now, it is generally related to obesity. However, it's not related in all cases, and it is oftentimes reversible. It's reversible, or you can at least treat the symptoms of it in many cases. Now, when we talk about PCOS, many women who have a 5 to 10% reduction in weight loss will see a reduction or decline of their symptoms because they're lowering that BMI, they're lowering the estrogen, and the testosterone goes down and symptoms go away. Or we can also use hormonal birth control, and this is why I'm answering this question right now, because when we use hormonal birth control, we are setting the rate with that estrogen and progestin. So we go back to here, right? Instead of your body deciding when we're going to have that estrogen and progestin, we're deciding. So using those pills, we're giving you a steady state of those medications. And so we're deciding what your estrogen and progestin should be instead of allowing your body to make that decision. And so when patients get a little worried about birth control, I tell them we're not as much adding hormone in our menstruating patients. We're more deciding what your hormones should be and then using them to our advantage, because many women's problems are a result of those fluctuations of your hormones, whether they're normal or abnormal, right? And so in regards to fertility with PCOS, if that estrogen is super high, it is working to prevent ovulation because you're not able to go, and I'll go back to our regular menstrual cycle just to illustrate this. Here we go. If you have a high estrogen at baseline right here on the third line, it will prevent ovulation because you won't get that fluctuation of ovulation from your brain because it's too high already. So you won't be able to release an egg. When you can't release an egg, you don't ovulate. And so that egg that was growing sits there and it doesn't release, becoming polycystic. And that is PCOS in a nutshell. I know it's hard to, again, I didn't grasp these concepts like, or remember them completely, but, it is one of those things that it does make it a little more easy to understand when you can understand that it's a disease of hyperestrogenism. So again, no problem. BMI, diet, exercise, and then two, hold on, did I jump ahead a little bit? I did, okay. All right, so we're gonna talk, I guess I missed that one. All right, we're going back to, so perimenopause. So menopause is the complete cessation of periods and where your estrogen goes down. Perimenopause is kind of this in between. It's generally happening in the ages between 40 and 50, where we see a gradual loss of ovarian activity, right? Your ovaries have a set number of eggs, a set number of estrogen a set amount of estrogen that they can release over time. And so as those eggs deplete, it becomes harder and harder to release the same amount of estrogen. So we go back to our feedback loop, where your brain has to put out more signal to get the same amount of estrogen. When that happens, you can have abnormal cycles. When your estrogen declines, you can have changes in skin, hair, breast and vaginal tissue, changes in libido, mood. For patients with very low estrogen, it can cause hot flashes, vaginal dryness. And so a lot of times I'm seeing patients with these chief complaints. And again, so right, our hypothalamus, so it's at GnRH, our anterior pituitary now needs to shoot out more FSH just to get that ovary to release the same amount of estrogen or same amount of eggs. And so in a perimenopausal patient, when I do labs, I expect that their estrogen is going to be a little lower and their FSH is going to be higher because the brain needs to speak more to the ovary to get it to function. Okay. When that happens, your cycles might change. You might go longer time between ovulation, and so your cycles might be abnormally long. You might think that you're skipping a cycle. And then if you skip a cycle, your estrogen or the endometrium can get thicker, and then you can have a much heavier period, if you're skipping a cycle. And that can be normal, or it can be a sign that something is abnormal. So really in this age where you're 40 to 50, the big thing is kind of, again, I stress BMI, diet, and exercise. A healthy BMI and diet and exercise are going to set you up for those later years. Healthy sexual habits, communication, using lubes, creams. Many women in this age group, they start to maybe shy away or enjoying sex a little bit less. And I try to talk to them about how can we increase their enjoyment. If we need to add things in, if we need to add in or change habits, communication about sex will set you up for a healthier sexual life. And also, this is the time where you're setting those habits up for later in life and maintaining health for menopause. So when to call, the biggest thing is abnormal uterine bleeding. If you're having bleeding where it's, again, heavier, we want to make sure there's no structural problems or no concerns, that we can always evaluate it. Or if your periods are abnormal, we can talk about how to regulate them to make them normal or figure out if they might be stopping. Women who go through menopause earlier, sometimes we'll talk about getting you on a low dose birth control to keep your estrogen or progestin where they should be, so that you don't have symptoms of declining estrogen. For many patients, we will recommend supplementation if they go through menopause before the age of 50, as long as they don't have any contraindications, because estrogen can have, like I said, a protective effect on your heart, on your bones. So we define early menopause as any women who go through menopause prior to the age of 50. So menopause, I know I'm actually running a bit behind, so I'm gonna speed up a little bit. And so, menopause is defined as the complete cessation of menses for 12 months, where you have little or no ovarian activity. The average age in the US is 51 years old. Your estrogen will be very low. Your FSH will be very high, generally over 40. It can be natural, or if you imagine if I took out your ovaries for any reason, or if you had surgery or radiation with ovarian failure or certain genetic disorders, your ovaries might burn out prior. And again, going back to this chart, you'll have high FSH, LH, low estrogen, and then eventually with all of that, you will kind of make this feedback loop burn out. So what to expect? So Many women will report that they have vasomotor or hot flashes. These can be, many times a day where they have a rush of sweating and even sometimes their heart might race. That can be very debilitating for some women. If some women just tell me that, yeah, they have them and it doesn't bother them. They might have vaginal atrophy because those sensitive tissues of the vagina and uterus are no longer getting as much blood flow. Mood changes, libido changes, osteoporosis or bone or tooth loss. They can have an increase of cardiovascular disease, sleep, skin changes, hair changes, memory problems. Kind of all of these things can happen to women. And so there are lots of lifestyle interventions for hot flashes. ACOG, or the American College of Obstetrician and Gynecologists, recommend, things that are, you know, um, making sure you have a fan and making sure you're at a good weight and that you're avoiding alcohol and not smoking. Kind of those lifestyle interventions, making sure you have light clothing. But there's also lots of medications that we can use to help if you're having bad hot flashes. Regular exercise with weight bearing and adequate nutrition. We recommend stop smoking, decrease alcohol, continued sexual activity. I don't, always say if you don't use it, you lose it. But I tell my patients that, continue sexual activity, even if that's masturbation. There are amazing websites that sell vaginal lubricants, moisturizers. There's aids to help with sexual activity for all different women of all different ages. And so, again, the habits that you set up in these 40s and 50s is going to help you going forward, because friction and sexual use helps vascularization, helps these tissues stay where you want them to be. So when to call me if you're having any postmenopausal bleeding, if you're having vaginal atrophy, which I know there's some questions in the chat, or vasomotor symptoms, or really any concerns whatsoever in these scenarios. Some women will talk about if they're having like genitourinary syndrome of menopause. So if they're having frequent urinary tract infections, if they're having discomfort during sex, if they're having any bleeding or bleeding during sex. And we can talk about these things, by talking to these things with the provider, they do improve quality of life a ton. And so kind of the OBGYN is the person I'm often fielding these questions from my patient. And so treatment for these things can be lifestyle changes, medications. They can be hormonal contraceptives in the premenopausal patient, or they can be just hormone replacement for some patients. It's going to be about talking to your healthcare provider. Hormonal changes can be natural. However, we have tools to intervene and can make people feel more comfortable. And so I just want to touch a little bit on treatments, right? So you're going to go online. You're going to say, all right, I'm going to take a women's vitamin and it's got, let's say, black cohosh to help with, postmenopausal hot flashes. Does black cohosh work? Yeah, for some patients. The data doesn't support that any supplements change things or help. However, bodies are weird. I tell patients that placebo effects are real. There are plenty of things that we take, whether it's creatine or, protein shakes, or, all of these things that data might not be supporting them 100%. However, if they make you feel better and they don't harm you, awesome. Keep it up. I wanted you to, maximize your nutrition and maximize all those things. However, I don't tell patients if they go take these things, it's going to make them feel better. It might, some patients, everyone's different. There's also antidepressants, and Veoza is a new medication that's a non-hormonal medication that is designed just for patients with hot flashes. If you have questions about that, please, reach out to me at any point. I can walk you through how it works and who it's for. There are patients who I see who come in with bioidentical hormones. And now bioidentical hormones are things made by a compounding pharmacy that are designed to look at your hormones, and they give you specific estrogen, progestin, sometimes testosterone. It's not recommended by the FDA, not recommended by us, because if we go back to our feedback loop, right? What day are they looking for those bioidentical hormones, right? If they drew it on day 1 of your cycle, it'd be very low. If they drew it on day 14, how they come to these bioidentical hormones is kind of up in the air. There's no data that says this is the dose that should be given, at this time. And then the route of administration is oftentimes pellets, or things that might have a a long-term effect. I have seen some patients with pellets who, are potentially, have these things affecting their hormones for a long time. And then I've also seen patients who are getting testosterone supplementation. Testosterone supplementation for postmenopausal women, you will have those male secondary sex characteristics. There is some data that it might help with sexual drive. However, estrogen seems to do a good job of that as well. And then there's plain regular hormone replacement therapy, and that can be with estrogen or estrogen plus progestin. We add progestin anytime someone has a uterus, because if I just gave you estrogen, it would make the grass grow too much and you would have bleeding. So if you have a uterus and we're giving you estrogen, you also need a progestin. So this was just illustrating for bioidentical hormones. So hormone replacement therapy, and I think a lot of people might have been waiting for us to talk about hormone replacement therapy. But what it is that we give a small dose of estrogen or a combined estrogen progestin. And when your body is no longer making it, it is FDA indicated for vasomotor symptoms, meaning hot flashes or genitourinary symptoms of menopause. Generally, I reserve it for women within 10 years of menopause. The closer they are to their menopause, the safer it is. And safer it is, we're talking about cardiovascular risk, right? Bonnie mentioned a question that with menopause, needing estrogen due to poor symptoms provoked a blood clot previously. What suggestions are there? So estrogen is a procoagulant. It makes you clot. When we look at patients, when I'm talking to them about hormone replacement therapy, I tell them that when taking estrogen, you are at a higher risk of having a blood clot. You're at a higher risk of having a cardiovascular accident or a stroke. That is because your risks as you get older go up, and estrogen is a procoagulant. Generally, I use a cardiovascular risk assessment calculator with each of my patients that I'm putting on. And I tell them, this is your risk of an accident in the next 10 years. Now, I tell them that risk, and I say, your risk goes up with administration of a hormone. Are you okay with that risk? In a normal patient, when we're starting postmenopausal therapy, generally their risk goes up sometimes twofold. I quote them, generally that is a risk from about 4 in 10,000 to 8 in 10,000, in a person who's not smoking. Can we lower that risk? Definitely. We can lower it by having a normal BMI, by not being hypertensive, and by using a dermal route of administration for their estrogen. Also using the lowest dose possible for the shortest time period. Now, how many provoked blood clots have I seen with my postmenopausal patients? Not many. Very, very low overall, because when we're talking about hormone replacement, we're talking about 1/20th, 1/30th of the dose of even a birth control pill. And we recommend the lowest dose possible for the shortest period. I usually start patients on a small dose with a patch. And then if we watch them for about 6 weeks. If their symptoms are gone in 6 weeks, then great. If not, I will slowly raise the dose. Now, what are some of the side effects? It can have a positive side effect on, vasomotor symptoms by stopping that. It can cause changes in mood, sleep, sexual function, skin, but can also cause abnormal bleeding, breast tenderness, bloating, headaches, kind of all of those things that can be hormonal driven. I had another question. So atrophic changes, are that normal in the menopausal patient, and when should become a concern? So vaginal atrophy in general can be concerning at any time, right? So if you're undergoing or if you're having vaginal atrophy, then I recommend getting an assessment, because vaginal atrophy in a premenopausal patient might be a sign that they're hypoestrogenic or their estrogen is low. It could be a sign that we might need to check your hormones or supplement either with a vaginal estrogen or maybe another type of cream. So, in a postmenopausal patient, we expect some atrophy. However, there are, as opposed to systemic hormone replacement, there are just vaginal estrogens. Vaginal estrogens have low systemic absorption and are very good when it comes to helping reverse or treat vaginal atrophy. However, they're not good at treating these other things because they're not going to the brain as much. So while it's very safe for patients who might have had a blood clot, patients who might have had other things like hypertension or smoke, it might be very safe for them, but it doesn't really affect those systemic symptoms. It will just treat vaginal atrophy. So I do use that in a lot of my patients. I use it in many of my patients who come in and they're 70 or 80 who are having vaginal atrophy or a little bit of atrophic bleeding. So I use it very liberally. It works very well for them. It doesn't come with all of the risks, but it doesn't come with all those benefits either. So when we talk about the side effects of hormone therapy, so before 1991, a lot more hormone was being prescribed by primary care doctors, including OBGYNs. And there was a very large study, it was called the Women's Health Initiative. And this was a series of clinical trials by the NIH, National Institutes of Health, that looked at cardiovascular disease, cancers, osteoporosis of women. It was looking at 160,000 women ages 50 to 79 and looked at interventions like hormone therapy, dietary interventions, calcium, vitamin D. It looked at estrogen, no treatment, and estrogen plus progestin. And this cycle or this study got a lot of publicity because it showed an increased risk of cardiovascular accident, stroke, blood clot, increased breast cancer with estrogen and progestin, and no less heart disease, right? So the old adage was that give everybody estrogen, they won't have a heart attack. Well, that's not true. It did show decreased bone loss and potentially decreased colon cancer. However, they stopped this, and kind of in that 90s, they demonized estrogen and progestin. But this reaction was very, now we know was very reactionary. There were a lot of troubles with this study and data. So the biggest thing was the average age. The average age of the patients in this were 63 years old. Those 63-year-olds, 40% of them smoked, another 40% were hypertensive. They gave people estrogen or progestin. It didn't matter if they were 10 years out of menopause, only oral pills. And so they had a much higher risk of adverse outcomes. We now know that initiation of these, we've looked back at this data, we've re-examined it, we've changed the confounders. If you're menopausal at an age that is normal, let's say age 51, and we start a low-dose hormone therapy at a younger age, you're at a very, very low risk for these adverse outcomes. Okay, you're at a lower risk for having a stroke or blood clot. Now, yeah, we can give you a transdermal route, which has an even less side effect profile than oral or estrogen, less risk of blood clots or stroke. Yeah, there is still a risk with these patients. However, we have to do what's called patient-centered decision making, right? The patient comes in and tells me they're miserable and they're having, brain fog and they can't sleep and they're having hot flashes, then I'm going to talk to them about estrogen. I'll talk to them about their risk factors. I'll calculate what their score is and I'll get them on a low-dose estrogen patch. Patients, this is totally safe with patients at a younger age. We do your mammogram, we do a breast exam, and we, look at the whole woman to keep them functioning and keeping them healthy. Will we stop at some point? Yeah, we'll have to stop at some point, but overall, it does have a protective effect on your bones, and it does have a protective effect on your cardiovascular health if we start it early within that year or two. So it does have a lot of benefits, and we can talk about those risks and benefits. So it's not one of these things that I demonize. Now, are you at a high risk for breast cancer? So when we look back at that data from the Women's Health Initiative, yeah, there was a slightly increased risk of breast cancer with the estrogen and progestin combined. However, breast cancer is super common in the United States. It's 1 in 8 women, or 12%. So if we have a shared decision making, it is something that might confer a slightly increased risk. However, it is not a greatly increased risk unless you have other risk factors or a known cancer. And really, that's just because you're continuing to have a small dose of estrogen and progestin, and those tissues are estrogen and progestin dependent. So, the most common breast cancers, estrogen and progestin positive breast cancers. So, it's just a statistical finding as opposed to we are causing it. Now, that might be different in a patient who has started on an estrogen or progestin after the age of 60. I would not jump to estrogen or progestin supplementation in a patient who hasn't had a period in 10 years, because they're at a much higher risk for all of those adverse outcomes. But, continuing patients on a low dose estrogen if they don't have something else going on, very comfortable doing that. And again, it's really just kind of mitigating those response so that, we're, uh, of kind of positively affecting that feedback loop.
Like to say we appreciate you all for joining us today, and we kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to that survey has been added to the chat for your convenience. Special thank you to Dr. Simmons for dedicating your time and expertise today. If you have additional questions or comments, you can send an email to communityhealth@atlantichealth.org or call 1-844-472-8499. And again, thank you all and have a great day.